बिल्कुल ठीक।
डियर व्यूअर्स, नमस्कार। आज के टॉक शो में देश प्रसिद्ध डॉक्टर अनूप वर्मा जी, जो कि रायपुर छत्तीसगढ़ से हैं, आज के टॉक शो में आमंत्रित हैं। आप आज के टॉक शो में आपका स्वागत और अभिनंदन है। आप आज बच्चों में मूवमेंट डिसऑर्डर पर अपनी राय व्यूअर्स को बताएंगे, जो कि एक संजीदा विषय है। इनके बारे में मैं डिटेल में जानकारी देना चाहूँगा आप सब दर्शकों को। आप इनकी क्वालिफिकेशन देखेंगे तो आप दंग रह जाएंगे। एमडी, एफआईपी, एफआईएमएस, एफसीजीपी, एफएपीएन, एफपीएआई। ही इज ओनर ऑफ स्वप्निल नर्सिंग होम, रायपुर, छत्तीसगढ़। Pediatric neurology and clinical genetics is the interest of his work. Had many publication, editor-in-chief in PI textbook of pediatrics, editor and chief in first and second edition of IIP textbook of pediatric neurology, author of Spotter in Pediatrics and Pediatric Secret, is the one of the finest book by him, and his more interest in his Spotter's editor IIP textbook of pediatric radiology. Doctor of Year Award by the National IMA 2015, FIP in 2003, FIAMS and FCGP in 2007, Honorary Fellow of Academy of Pediatric Neurology for 4 years, DS Oration CG State 2017 Award, Oration Award, SJ Ghatak Oration Asansol 2018, Manas Mukherjee Oration Havra 2022, and TB Prasad Memorial Oration Ranchi 2022. National EBM IIP in 5 times, 2000, 2005, 2012, 2014, 2015, shows his interest in the fine movement of the organization. Nice National Vice President in IIP in 2005, National Chairperson Academy of Pediatric Neurology 2008 and 12. CGC member, CWC member of Central IMA 2007, 2009, 2011, 2012. How he spare time from his pediatric practice, which with so much rush, I cannot understand. CG State President of IIP 2006, CG State President IMA 2007, IIP Constitution Committee member 19 and 20, Central Zone Coordinator of ECD 2022 and 23. He's going to talk on the approach to the movement disorder in a resource poor setting. You are welcome, sir.
Sir,
And
thank you, sir. Thank you.
I request to start your talk with the slideshow.
Sir, thank you so much. Before I connect with my presentation to audience, I just want to spare few minutes for you. And we all know that some people inspires by their words, other by their work, and a rare few by a sheer force of their authenticity. Dr. Tuteja sir belongs to that rarest category. Respected colleague, it is my absolute honor to speak about Tuteja sir, the senior-most pediatrician and revered adolescent counselor, whose clarity of thoughts, fearless voice, and unshakable authenticity have been a beacon for the entire Indian Academy of Pediatrics. For decades, his words have been heard not because they are loud, but because they are true. He is a voice free of politics, untouched by bias, and strengthened by the sincerity with which he puts forth his voice. Even today, despite the passing of years, he tirelessly managed adolescent India, shaping and sharing the voices of pediatricians across the country, unedited, uncensored, and unfiltered. And we cannot and who cannot forget the Tuteja talk show which we are present today. The first and only of its kind in the IFP arena, a platform where knowledge flows freely, camaraderie flourishes, and learning become a shared celebration. We call him young Tuteja, sir, not because we ignore his seniority, but because of his infectious energy, zeal, and enthusiasm with which he engages with every generation, from young residents to senior stalwarts of pediatrics. We all know that age is counted by years, but youth is measured by curiosity. And, sir, you remain forever young. Dr. Tuteja sir is not just an asset of IFP. He is an asset to Indian pediatric fraternity as a whole and beyond. For me personally, he is a guide, a source of inspiration, and my big brother. Thank you, sir, for your enduring contribution and for giving me the privilege to share the stage with you at this mega show. I am confident that our discussion on movement disorder today will be both meaningful and enriching, benefiting every pediatrician present here. We all know that some inspires you to think, other inspires you to act, but the greatest inspire you to become the best version of yourself. Thank you, sir, for being that inspiration to me. I'm I'm sharing my presentation to you. Just a minute. And sir, is it
Yes, sir, visible.
visible, sir? Okay.
Yes, sir.
So my topic of today's presentation is a very, very pertinent presentation, approach to pediatric movement disorder in a resource poor city. Think of a pediatrician in the remote area, a district place where CT MRI is not possible or genetic test supporting your diagnosis is not available. And this presentation is going to give you clues and in the form of a total visual atlas. You name a movement disorder, and here it is present here. So if it walks like a duck, quacks like a duck, it is probably a duck. So it is very, very important that pattern recognition, you listen the voice, you see a movement. This is what is the pattern recognition. So syndromic pattern recognition. If he walks with a twisted posture with contracted muscle, it is probably a dystonia. And if it looks like a chorea, moves like a chorea, it is probably a chorea. So my approach, the aim of this presentation, it is the presentation which you will never heard in early future with a very different concept. You will going to listen the pattern recognition with a metaphorical approach. What is this metaphorical? That is the poetic expression of each moment disorder, which you will never find in the textbook. But definitely, if it comes in your mind, you can match the metaphorical verse with the abnormal movement. You are going to see the spotters as well. You are going to see the examination of eye in the movement disorder. So here the presentation is this patient is exhibiting abnormal movement, and we all know that the continuous flowing movement is there, and definitely the phenomenology is the chorea. So now you are seeing the irregular, jerky movements, and I have also given the picture form of the abnormal movements. Apart from the metaphorical verse, you are also going to see the graphical design of the which you had never seen in the future and in the past. Yeah, this abnormal movement, this fidgety, this tractability movement is there. So how you define in Korean metaphorical way that Korea is the dance of disobedient neurons, graceful, chaotic, and never at rest. So that flowing, unpredictable nature of the coriform movement reflects the basal ganglia chaos. Repeated blinks child is exhibiting. Definitely, it favors the diagnosis of the tics. Brief, repeated movements you are seeing. There is a presence of urge or sensation preceding that. It could be simple or complex, and suppressibility can be there to the extent of even temporarily. You are seeing all sort of various abnormal moments. You are seeing these are all patients exhibiting different sort of thing. We know that it could be a simple motor tic like blink, shoulder shrugging, facial grimace. It could be a complex sort of thing, touching the object, spinning around and jumping. Tics are the body's whisper that becomes a shout when ignored. And this is the important message that the body, the patient is giving you a clue. Try to perceive it, try to catch it and pick up it so that it may not become ignored. And it is true for turning the tics into a Tourette syndrome. Like urge release cycle and psychosocial overlay is an important feature, especially in the Tourette syndrome. Another patient with exhibiting very painful twisting contraction of the muscle, and this is a classical phenomenology of the dystonia. We all know that the overflow movement are also a feature of dystonic hallmark. Very painful contraction is there. So dystonia bends but never breaks, twisting the child into poses the brain never intended. So it emphasizes the sustained, painful, and often function-limiting nature of the dystonic movements. Here is the patient. Just see sudden shock-like jerk. That is the electric shock is there. So this is the classical phenomenology of myoclonus, and we all know that it is a non-rhythmic, brief, short shock-like jerk is the myoclonus. So myoclonus is the startle of nervous system, sudden striking and without warning. So it is a perfect for you to describe it as a sudden lightning like jerk. Another patient, see the tremors. The patient is exhibiting oscillating, the symmetrical velocity on both the sides. So it is a rhythmic oscillation. And the patient, this is a talk of every OPD. You are giving now, the season is on of cold, and they are given bronchodilator drops, and you are seeing the tremulousness, symmetrical velocity. This is a classical drug-induced tremors. A tremor is the body's echo of indecision, oscillating between action and hesitation. Another patient, see the continuously breathing, rapid movement, face, hand washing sort of movement is there. And this is a classical feature of stereotypy. The midline stereotypy is the feature of Rett syndrome. And you can see the repeated stereotypy, similar continuous movement the patient used to do. So stereotypy is not purposeless. Always remember that it is a rhythm of comfort in a world of sensory chaos. We all know that the rat is having the sensory issues, and but they do stereotypic movement because they find comfort in doing all this stereotyping. So it is useful to reframe stereotypies not as an abnormal behavior, but a coping mechanism in the neurodevelopmental condition. So, friends, we all know that if it walks like a duck, it quakes like a duck, it's probably a duck. So, we come prepared for the spotters as well, and you are going to witness various abnormal movement, and you have to diagnose this. Here is the first failure. The patient has ceased the breathing during forced expiration. There is a circumoral sinus. See the picture as well, the graphical design, a tonic spasm of the limb. So, friends, when the cry goes silent and the child turns blue, it is a spell, not a seizure passing through. So, this is a breath holding spell. Another patient, you see the rapid shivering of the head, trunk, brief duration, and you can see the when the body quivers, but the child stay bright. It is a harmless shudder, not a seizure fright. So this is a shuddering attack. It is not the patient is bright. See the in the background, parents are also looking bright. They didn't have any problem with this abnormal, but definitely few patients come with what is happening. There is a seizure activity like that. So this is a shuddering attacks. These are the group of patients all exhibiting shuddering attacks. They have been referred for the diagnosis by several pediatricians and the parents as well. Another patient, forward and backward head movement. You can see these are the abnormal movement when the ventricular cyst is there in the third ventricle cyst or aqueductal obstruction is there. When the head nods like a doll in play, think deep midline cyst along the way. So this is a bobblehead doll syndrome. You just see up and down head movement is there, 1 to 5 hertz, repetitive and rhythmic movements are there. What is this? When the nod repeats in a rhythmic rhythm tight, it's a harmless habit, not a worrisome sight. So by definition, by just means caption, you can see that this is not it is just a harmless habit, not a worrisome sight. So this is a head nodding stereotypy. Another patient sees such a magnitude of the head banging. So what is this? Not all the knocks are cries for help. Some are lullabies of the self. A gentle reminder that not all repetitive movements are pathological. This is the head banging. Another patient, see the rhythmic severe head banging, but it is occurred during sleep. So the crib may shake, the brain does not. Jactatio in is sleep's harmless plot. So this is a jactatio capitis. This is seen during sleep. Another patient, see the type of movement child is exhibiting in the figure of 8 sort of manner. So this is it is seen in the congenital brain malformation when the vermis are absent or vermis is fused in the figure. This is the raw. If the vermis fails to part the way, the head may sway like an 8 in play. So always remember, if the child is exhibiting head abnormal movement in a figure of 8, try to center your thought towards the vermis. So this is a rhombocephalosynopsis. Another newborn, this is a common mistake that they are being considered as a seizure and be kept on phenobarb and phenytoin or levetiracetam, but without any result. So this is a abnormal movement. This is a myoclonus, but it is only seen in during sleep. So this is a benign neonatal sleep myoclonus. When the jerk dance in sleep, but vanish with wake. Let slumber soothe, no need to quake. So this is the benign neonatal sleep myoclonus. Another patient, recurrent episode, head tilts to one side, onset in infancy. So what is your diagnosis? When the head tilts, don't always fear. If it comes and goes, the end is near. So this emphasizes the transient self-limiting nature of benign paroxysmal torticollis. Another patient, see the torticollis. See, you are also seeing the head is nodding and there is a small component of the bilateral nystagmus. This triad is very important. When the eyes dart, head nods, and the neck tilts too, think of mutans before you pursue. This is a classical triad of spasmus mutans, which is absolutely benign condition. So let us see more. This is a follow-up of the same patient for at least 14 years. And he has become now 2 years more, that is 16 years as well. So this is the cortical is gone and the nystagmus gone, but he has some refractory issues as well. So the when nodes, nystagmus, and torticollis unite, think benign first, but scan to be right. If the nystagmus is unilateral, try to have a CT scan or neuroimaging for the chesmal mass. These are all patients of spasmus mutans. You can very well see that there is a torticollis, head nodding is there, nystagmus is there. A wobble, a wiggle, a twist of the head may vanish with time, not fill you with dread. Another patient, On an attempt to chew, the upper eyelid moves. You can see all the four videos. If they are giving something to eat or chew, the upper eyelid is moving. This is what is known as you can see. If the eyelid jumps with every bite, if the eyelid jumps with every bite, it is not a trick, but a synkinetic sign. There are two cranial nerves which become synkinetic action. That is the C3. Always remember the formula C3 and C5. That means third cranial and the fifth cranial nerve by somehow congenitally they are fused and work like in a synkinetic way. So this is a Marcus gun phenomena. This is or jaw winking phenomena. These are all patient of jaw winking phenomenon. Always these are the 2 month of old child. This is 4 month of old child. You can see. So a chew, a suck, a sudden blink. Marcus gun is the missing link. Always remember these captions. Another patient, see, received some drug in the periphery. There is a severe torticollis there, and this is a common scenario when the patient has received some antiemetic drug. So a gentle touch can tame the twist or trick that dystonia can't resist. This is a very important clinical sign that when the twisting or the very severe spasm, retrocollis there, the patient try to put the arms like this in the, see what this is doing. See, this is a sensory trick. This is a very sensory trick and gives relief of the spasm. So this is a gest. It is also known as the gastri antagonistic. Another patient, see the retrocollis. See this amount of severe painful dystonic spasm is there. So when the neck arches like a bow, think of drug that is steal the show. So it is an acute dystonia retrocollis. Another patient, see the upward conjugate deviation of both the eyeballs upwards. Why? Because he has been given some injection at the periphery, and this is classically known as a we'll say when the eyes roll to the skies, suspect the drug that underlies this is the oculogyric crisis. So always remember, not all upward gaze is divine. Usually, people see in the upward sky by to look for the God to help, but not all upward gaze is divine. Some needs promethazine in time. So stresses the importance of anticholinergic treatment in the time. Another patient, you cannot protrude your trunk for more than 2 minutes or a minute. This patient was protruding the trunk for more than 20 about 2 days. Such a painful condition was received. This patient received some drug from the periphery. It was acute lingual dystonia. When the tongue protrudes out in this silent pain, the culprit drug must take the blame. This is the drug-induced lingual dystonia. A stiff tongue, twisted fate, anticholinergic safe before it is too late. Always try to use promethazine or benzotropine promptly. All these patients are having a lingual dystonia, as you is seen in this. So if the tongue protrudes when and won't obey, tongue is not obeying you. If the tongue protrudes and won't obey, stop the drug and treat it today. Another patient coming with abnormal circumoral dystonic movement is there, lingual dyskinetic movement is there. Way back after 7 to 10 days, more than that is the tardive nature. This is the tardive dyskinesia when the tongue twists and the face grimaces weeks after a pill. Think tardive time reveals the ill. So this is a tardive dyskinesia. Now you are seeing a patient who is lifting the eyelid upward. That is this, and it is episodic, not like an oculogyric crisis, which is a continuously. This is a episodic. So this is a when the eyes rolls up without a cause of cry. Think benign before you classify. So this is a benign paroxysmal tonic upgaze, PTU. We commonly call it PTU, paroxysmal tonic upgaze. Another patient, when after getting the milk, the patient arches backwards in the opisthotonous position, and when the spasm mimic a seizure, but the feet tells the tail, think of reflux in this twisting tail. Always remember that this is a the Sandifer syndrome or severe gastroesophageal reflux. Another patient, CP patient, this is a dystonic tremors that we are showing here. When tone twists the limbs and tremor tracks alone, dystonia dances where control is gone. So this is a dystonic tremors. Now, few slides for how eyes are helpful in diagnosis of abnormal movement. Another, see the eyes, conjunctival tortuous conjunctiva. When shaky steps, that is the ataxia, when the shaky steps meet the red eye, that is the tortuous, that threads. Think ataxia, telangiectasia before it spreads. So it is a very important clinical condition which can be picked up just by examination of the eye. Now, here you are seeing the dark, a ring of rust, a brain in fuss. Wilson disease has come to discuss. You are seeing a classical yellowish ring over the decimate membrane, and it can be picked up by naked eye or by the slit lamp. Another thing, you can see, just observe the eye, chaotic eyeball movement. You will never see such type of beautiful video, and the diagnosis is written on the face. If the gaze refuses to rest and the child regress, OMAS may be the unseen gaze. OMAS is the opsoclonus myoclonus ataxia syndrome. Another patient, oculogyric crisis, which we have discussed earlier. When the eyes rolls up and freeze in fright, think drug, think dystonia, and act right. Another patient, when the blinks repeat without the need or cue, a simple tic may be passing through. You are LLC, see the horizontal nystagmus, maybe sometimes vertical as well. When the eyes wobble and step go wide, that is the eyes wobble is the nystagmus and step go wide is the ataxia. Suspect the cerebellum slipping guide. So it is the cerebellar ataxia. Now, you are seeing a video where the small child is having a tremors of the chin. Upon asking the parents, the father is also having the tremor of the chin. So this is a classical example of hereditary chin trembling. The chin trembles, but the gene speaks. As we all know, it is a autosomal dominant condition, repeating a silent family rhythm. You are seeing the two more patients of chin trembling. I was going to US and one Englishman was sitting in front of me, and I gathered that his ear was abnormally moving. So by with great difficulty and putting the camera here and there, I just mobile, just I could take the snap, and you can see this abnormal abnormal ear movement, and this is the auricular dyskinesia. When the ear twitches without a tune, it's a silent hint of a hidden immune. So this is a auricular dyskinesia. Another, I just gone to Pune and just after taking the taxi going to hotel, my taxi driver was doing abnormal movement. I was surprised and think that in a strange city when nobody knows you in the ambience and your driver is doing like that, protruding tongue and abnormal movement, what will be your position? I immediately gathered that this is a simple motor tic the driver is exhibiting, and I kept silence and by great difficulty took the video of this child. So when the wheel stays straight but the head keeps trickling, the motor tic may be quietly clicking. So friends, diagnosis does not wait for the clinic. When the eyes are trained, the street becomes a classroom. Always remember, diagnosis does not wait for the clinic. If your eyes are trained, a street becomes a classroom. That we have to remember. So, in a resource poor setting, what we have discussed all this lecture, all this slide, we have not gone with the MRI, we have not gone with the genetic test. You need only a torch, you need a hammer, you need a basic workup. And also sit in your clinic with immense clinical interest, and you can pick up lot many. So friends, learning disease is never complete and presentation of disease is never final. So we have to churn your experience. You have to churn your experience with the available science, available literature to come to conclusion. And so I have tried to make movement disorders, the spectrum of movement disorder in a very simpler way, so that you can pick up in your clinic where the facility is not available just by seeing the abnormal movement, classifying it, interacting with your seniors like that. So this, along with the metaphorical words, a poetic expression, which is very new for this presentation. Thank you to Tuteja sir for your kind permission to uh, stop this. Thank you, sir. For I think that in 20 minutes I have finished my talk with a huge amount of information, interesting captions, interesting videos for all the audience. Thank you so much, sir.
डॉक्टर अनूप जी, आपने कमाल का काम करा है। मेरे ख्याल से किसी टेक्स्ट बुक में मैंने को तो आज तक इतने वीडियो नहीं देखने को मिले। एंड द विजुअल इम्प्रेशन विच you have given to the viewers, pediatrician and the public, is an extraordinary work which you have done. And I think that जैसे हम लोग बोलते हैं कि बच्चों को कुछ बोलते हैं तो याद नहीं रखते, पर देख के जो चीज़ें देख लेते हैं तो हमेशा याद रहते हैं। तो इसी तरह से इस प्रेजेंटेशन का the main aim of this presentation is the visual impression which you are giving with your talk and about the disease. That is very important. So all the viewers, when they see such patient, they will remember that Dr. Anoop Verma has shown this picture to us, and this is the diagnosis. This is a real helpful. I think that in any textbook, I cannot see
नहीं,
such pictures. And you are in your travel also, you have collected so much, really, that shows your motto
नहीं.
and the devotion to the cause of pediatric neurology. Thank you so much for giving time to Dr. Tuteja talk show, and I am sure the viewers will enjoy it and they will remember the videos. And if you are liking our resource persons and the talk show, please subscribe it so that I can devote time to the other things to improve more things for the pediatrician and public and for kids and for adolescents of our country. Thank you so much being with us.
Thank you, sir.
Thank you so much. We will meet again
Thank you,
with
sir.
some other topic.
Thank you.
Thank you so much, sir.
Thank you, sir, for the honor. Thank you so much.